My name is Mansuyo. I'm assistant professor here is MU School of Social Work, and then I also have a joint appointment with the Master of Public Health program. So I like to introduce our panels. The first time, so we'll have Mr. Jeremy Milaski. So Mr. Jeremy Milaski is the navigator program manager for Primaries, a healthcare firm which leads a coalition of federal navigators. Mr. Milaski has a master's degree in public administration from MU. And then our second presenter will be Dr. Bethel Sanders Thompson. So Dr. Thompson is an associate professor, George Warren Brown School at Washington University in St. Louis. Dr. Thompson received her BA from Harvard University and her master's and PhD from Duke. Dr. Thompson is also currently serves as director of community outreach for the program for the elimination of cancer disparities. And she also leads the career development core for the National Cancer Institute. Okay, so our last panel will be Dr. Ken Holler. Dr. Holler is an associate professor of pediatrics at the St. Louis University School of Medicine. And Dr. Holler is also SSM Cardinal Glenn Children's Medical Center. And then Dr. Holler is a president-elect of the Missouri chapter of the American Academy of Pediatrics. And then Dr. Holler serves on the board of Missouri Foundation for Health. Dr. Holler has served as president of the St. Louis Pediatric Society, PROMO, Missouri's statewide LGBT civil rights organization, and GLMA. So each panel will have 20 minutes, and then after our presentation, so we can have some question and answer. And then please keep that in mind that you have yellow sheet, and then so if you have any things like potentially the implication for actions, and then please jot that down on the yellow sheet. Okay, so please welcome Mr. Jeremy Milaski.
Thank you very much. The title for my presentation today is the phrase "wood to hill." It's a clumsy attempt at wit. I was thinking of the last scene of the Shakespeare play Macbeth, and basically Macbeth is told that he can't be defeated unless the forest comes alive and charges up the hill at him. Well, the enemy soldiers disguise themselves as trees, and then they come and they do away with Macbeth, basically. And it is my hope that this presentation gives you some kind of inkling of what was going on the ground for the last 6 months during this first open enrollment period of the health insurance marketplace. So we don't literally miss the forest for the trees and end up like poor Macbeth. First, I would just kind of want to introduce who we are and what Primaris is. Primaris is a federal health contractor, public health contractor, has been for about 30 years. We mostly work with providers. That's how we started out as the Medicare Quality Improvement Organization for Missouri. And basically, in English, that means that we work on best practices to help providers learn from each other. In addition to that, for about 20 years, we've provided unbiased counseling for Medicare patients to help them understand their benefits and not sell them insurance. So every year for the Part D program, you get to choose between private prescription drug plans as a Medicare person, and it would be good to have somebody that's not an insurance agent show those plans to you and help you compare them, figure out what's the best choice for yourself, your family, your budget. And if that sounds very similar to what we do for the marketplace, it should. That was the experience that we brought to this work. But we don't do it alone. We have a coalition of partners around the state, and there are about 10 of them. And the way I describe this is it's kind of like a laboratory experiment with 10 different laboratory experiments going on around the state, and some of them turn into nice little potions that work, and some of them kind of fizzle and poof. And we basically took this decentralized approach where we figured, okay, these are mostly nonprofit organizations and healthcare organizations that are providing in-person assistance to help people understand the new system, and if they choose, help them enroll in plans. Most people getting financial help to buy those plans, because in the private insurance market, a lot of people would be priced out of that private insurance market. So some of these partners took the approach of appointing existing staff or hiring new people. Many of them took different approaches for outreach activities, how to get the word out about the new marketplace. It was not easy, but we learned a lot of important lessons. And toward the end, we were able to enroll more than 1,000 people and counsel more than almost 8,000 people. So, and that was a big part of it too. It wasn't just enrollments. It was helping people kind of understand what was going on. We also received a grant from the Missouri Foundation for Health to do similar work in central Missouri. So anyway, I wanted to get to this chart. I've lived in Missouri for about 5 years now. And I saw the license plates, and I thought, well, the state motto is "Show me." Everybody says "Show me health," etc. It's the state motto is not "Show me," to my surprise. It's actually a phrase in Latin. It's "Salus populi suprema lex exo," which means the health of the people should be the supreme law. The health of the people should be the supreme law. That's our state motto. This is how we do in terms of health coverage, or how we have done in terms of health coverage. Missouri tends to fall, in a lot of measures, tends to fall toward the middle or maybe toward the bottom of certain measures. If you look at the percentage increase by state in terms of the people uninsured, for the first decade of the 21st century, Missouri had the highest increase in uninsured people. So our problem of non-coverage is almost, you could argue that it's more acute than other places. We have a big coverage problem, or had a big coverage problem. This is, and many of those folks are, again, they're in vulnerable populations, what the federal government calls vulnerable populations. These numbers are the number of people that we chose, or the characteristics of people that we proposed to serve for this first year. The latest media cycle has kind of focused on the number of signups. And you probably saw one of the other presentations had 8 million in big, bold letters with colors around them. And I mean, we can take credit, I guess, for a little bit of that, but the purpose of the Navigator grants, the purpose of in-person assister programs, people to help you sign up or understand the system in person, was not necessarily about that population. It was about the population that we're here to talk about today. The people that fall through the cracks. The people that are less likely to be covered. That are less likely to be able to understand their coverage. And I probably don't need to show this slide to this group. Obviously, coverage is extremely important. If you are not covered, you are more likely to file for bankruptcy. You are more likely to avoid preventive care, to get your preventive care in an ER. And yes, you are more likely to die. There's peer-reviewed studies that show the mortality rate is actually higher. I mean, surprise, surprise. I mean, many times we do these data studies and it proves something that's anecdotally obvious. This is one of those. You are more likely to die if you're not covered. There's also a cost element to all of this. Uncompensated care, according to the Missouri Hospital Association, cost $1.3 billion in 2011. That figure is projected to go up by that. And there are, and again, that is just an unsustainable system. That was one of the arguments that we made for doing this, for why we were doing this. Additionally, this is something that's not really cited a whole lot. The way the subsidies are structured in the marketplace, the way the financial assistance is structured, if you take 5 people who do not have access to affordable care in Missouri, not have access to affordable coverage, 2 of them have access after subsidies. have access to at least one plan where the premium is 0. And think about that for a second. That means that those people have not a political choice, but a practical choice. They have an economic choice. A choice between coverage that is basically free or a tax penalty. And that was one of the arguments we were trying to make. And it was, I'll be completely frank. There were periods during this open enrollment period where there was not as much traffic to us as there should have been. It was really, if you think about how it kind of rolled out, what happened was Navigator grants came out. The funding was somewhat low from the federal government. So the Missouri Foundation for Health, thank goodness, stepped in and created their own grant program for in-person assisters. There were also some funding for the federally qualified health clinics for them to do this work. But there was this big concern there wasn't enough assisters. And then, October and November was well covered. There were problems with the implementation with the website. And then in December, there was a big spike in traffic. And then January, February kind of slowed down again a bit. And so getting the word out about this was a big challenge. Most of us approach this like social workers. Well, we're going to do counseling for people, and we're going to empathize with them, and we're going to talk, we're going to make sure we educate them. But there was this sales and marketing approach to it as well. 2 weeks into the open enrollment period, I was invited to lunch with the regional director for Health and Human Services, and I thought it was going to be this luncheon. And I show up at the restaurant in St. Louis, and it's just her. It's just Stephanie Moore. And I had lunch with Stephanie Moore, and I'll never forget this. The server brings us our check, and the regional director puts when the server brings us our check, it puts this nice little card on the table. It says Health Insurance Marketplace on it, and asks the server whether he's covered and whether he has health insurance. That is the kind of thing that it took to get people enrolled. The best navigators, remember we had this thing about the experiments all around the state, and we got to see who was doing well and who wasn't. We were very keen on that and very keen on performance measures. The best navigators in Missouri, or CACs, excuse me, don't want to split terms, were the ones that were relentlessly, militantly positive, the ones that did not stop, that talked about the ACA, that talked about coverage, that talked about the financial aid wherever they could. In bars, in restaurants, in beauty salons, daycare centers, they did not stop. And they're the ones that actually got the enrollments. The ones that expected the folks to come from them, they had a hard time. Okay. The biggest disparity, bar none, in all of this work was technology. It was related to technology. The marketplace is basically a web-based system. Yes, there's a call center, and yes, there's us, and yes, and yes, you can go by phone, and yes, there's paper applications. But honestly, the primary way for people to get enrolled was through a website. Through a website that required you to have an email address, that required you to have at least somebody helping you, if not you, have access to a computer with internet access. So if you were the kind of person that didn't do that, wasn't a web person, maybe had a hard time remembering passwords, you were more likely to fall through these cracks. I'll never forget this one. There was a gentleman that saw me in November who had brain surgery, and he was an older gentleman. And if you didn't know him and talked to him, you think, okay, here's an older gentleman who's not good at the internet. That doesn't surprise anybody. This man had brain surgery and physically could not remember passwords. So our program, and we captured hopefully at least a significant number of people. Our program was meant to help those people. The biggest disparity again was technology, and it took longer to help those people. Another part of our grant was being trained in cultural linguistic assistance. So some of our partners were specialized in assisting newcomers to the country. One Bilingual International in St. Louis. That's what they do. They help the Bosnian population. They help different folks who are Korean population, etc. And We did find, obviously, this isn't going to shock the world, that it takes longer to help people with culturally linguistic assistance. So, a lot of folks, again, we're focused on those enrollment numbers and how many people can you enroll. Well, this takes a long time sometimes. And it takes longer for people who are more likely to fall through those cracks. Okay. Now, obviously, you are more likely to have to be of benefit, to get a benefit from the new marketplace if you are in a racial or ethnic minority. You are less likely to have employer-sponsored coverage. And one thing, I did want to touch on this. This is going to get a little bit down the rabbit hole for policy. Mr. Bao talked about people who are legally in the country, who are here less than 5 years. There's this thing called the 5-year bar. If you are here less than 5 years, you're not eligible for Medicaid due to your immigration status. There is a provision in the Affordable Care Act in the marketplace that actually allows you to, if you are denied Medicaid based on your immigration status, you can get subsidies on the market. You can get subsidies for private plans. Okay, so normally, if you're below 100% of the poverty level, if you're in an expansion state like Iowa, then you get Medicaid. If you're in a non-expansion state like us, you're in the Medicaid gap, and there's no coverage available to you. Immigrants who are denied Medicaid based on their immigration status are the only people who are below the poverty level who can get subsidies in the new system. Many people do not know that. So there were a lot of people who were newcomers to the country who we helped who were able to get affordable insurance because of this. It is complicated, unfortunately, as I can see from the expressions in the room as I went over that. That was like just a little tip of the iceberg about that stuff. Okay, so we definitely had to meet people where they were. We had to just kind of keep it professional, not get into the weeds too much, just talk about how this can help them, how this can help their families, and we definitely did not tell people what to do. There were so many people who fell through these cracks that wanted a navigator or a CAC to tell them just what plan to pick, and we don't do that. We just educate people. All right, so I'm running out of time. I will close with this. This was not easy, obviously. This was a first pancake year of the Affordable Care Act in a lot of ways. The pancake was not round and well-formed like subsequent pancakes are. It was messy, but we were able to help a lot of people understand this system and in many cases, get some kind of coverage. Not all of those counseling sessions ended in enrollments, but that's okay. A lot of people ended up in Medicaid and CHIP, and that's fine. They got some kind of coverage. And everybody who did this, who helped with education, who helped with enrollment, who helped us get to places, who hosted events, they'll be able to look back and say they were there for this new era in healthcare. All right, thanks very much.
So I'm going to switch gears just a little bit, and I'm going to talk actually about how we talk to people about issues of disparity, how we communicate health messages effectively in disparate populations, and what that may mean for how providers speak with people, how we use media, the sources and channels of our communications, and some things for us to think about into the future as we attempt to eliminate disparities, increase equity, and transform the system or lack of a system for health care. So I'm going to discuss the role of culturally appropriate health communications in addressing disparities, and I'm going to try to present some examples of things we've done, efforts that we've made to use culturally appropriate health messages. And some of the things we've learned about things that we commonly do that probably we should rethink. Sometimes data is meaningful and turns out to be counterintuitive. And I think it's instructive in some of the things that we've found. So there have been many attempts to address cultural appropriateness of health communications, interventions, and promotions. Unfortunately, a great deal of what we've done in this area has been rather simplistic and remains somewhat simplistic. And so I want to start out by talking about some of the things that are involved in trying to move us forward in this area. One of the things that we find is that there's very little attention to theory and how theory should be applied to health communication and what we do, and the appropriateness of the theories that we do have and the theories we do use. And then you have to think about the selection of appropriate cultural constructs, ideas, and measurement. And that becomes difficult because the issue is, what is culture? And when you start thinking about this in an academic environment, you know, the definitions are many. We become so expansive that some people question whether culture means anything. But the thing that I always remind people of is that we are all embedded in a cultural context of some sort, whether we are aware of it or not. There is no such thing as a particular person or a particular group having culture. Everyone has culture. The issue is that most of us are not made aware of our culture because we live in it each day. And to us, everyone around us is doing something odd. They have culture. We don't. We all have culture. But here's the rub. No individual in a cultural context is going to embody every aspect of that cultural context because we are individuals. And no matter what culture you're thinking of, people pride themselves on their individuality. Even in collectivist cultures, there is an element of individuality. And so people select how much, what aspect, to what extent, when, where, how they embody the culture that helps to shape who they are. That doesn't mean culture doesn't matter. It just means that we have to understand it in its full complexity and resist the temptation to make it overly simplistic. Intersectionality becomes important in this work for that reason. It's important to understand the ways that certain characteristics of the individual combine with that cultural situation and that particular individual's motivations to use various aspects of their culture. So how does socioeconomic status interact with race, ethnicity to affect what cultural issues are of importance? How do those things relate to how people go about seeking information, what they consider informative? How does region, socioeconomic status, and race ethnicity affect perceptions of the information, perceptions of the treatments being described, the interventions suggested or recommended, that person's particular information and treatment needs or preferences? All of these are things that really need to come into sort of play. And so there are three major tasks in the production of culturally appropriate communications or interventions. You have to have the theory and cultural constructs to organize the intervention, the messaging. You have to integrate the appropriate cultural elements into the program, the treatment, the intervention. Consider things like channel, source, message content. And most importantly, there has to be some inclusion of community vision and voice. And one of the things that I say to people is that no matter what cultural constructs we decide to focus on or what strategies or issues from communities, we have to have that particular community's interpretation of that meaning. And what you find is across communities, those constructs have different levels of intensity and expression. And it is important to understand the implications of using a particular one in a particular setting. So community vision and voice becomes important. How do we obtain that? And then how do we make use of that? And you probably, most of the sessions I've been in, I've heard a lot about community-based participatory research. I tell people I like CBPR, but reality is what we're talking about is community engagement. And if you're not an advocate of CBPR, what you have to remember is that then you need to find the alternative forms of community engagement. The forms of community engagement are many, but you have to have some level of community engagement to do the work well. Now, the model that we most often use in our lab and in the work that we've been doing focuses on, there are really 5. I put 4 up, but there are 5, and I'll tell you what the 5th one is. Strategies for doing culturally appropriate work. Particularly in health information and communication. One is the use of peripherals, but even in an intervention, you have to think about this. And this is just using pictures and other images. It's even the headlines, the titles, the language you use, because language communicates things to people. So you've got to get those sort of just mundane pieces in place, just as a basic. The linguistic, which I listed as the 4th, actually is considered the sort of baseline common denominator, most fundamental. You have to use the appropriate language. The materials and services have to be in the primary or preferred language. You have to think about dialect. And I also include health literacy in this area. When people talk about linguistic issues, they often sort of parse out health literacy and put it to the side. But even if you're talking about a person's use of a different language, that when you translate or if you're interpreting, it has to be done at the appropriate literacy level. So for me, the literacy level and health literacy fits right into that linguistic set. We talk about evidential considerations. What statistical evidence? What actually is considered evidence? We typically think of statistics when we're in public health and when we're in medicine and when we're academicians, but people don't necessarily think in terms of statistics as evidence. They think in terms of stories, narratives, anecdotes. That matters. And so when we're communicating, we have to think in terms of what's the best use of those evidential strategies, integrated in, or using those to convey our statistics in ways that are useful to the communities that we're attempting to serve. And then there are those social cultural issues. I think Ken Resnick calls them deep structural issues of culture, but it's integrating health information, integrating interventions, talking to people about this in the context of cultural norms, values, and beliefs. If we're talking about diet, how do we incorporate the best elements, the favorite element, the preferences for diet from that community? If we're talking about physical activity, how do we translate that into terms that people can fit into their everyday life, not the things that we would typically think about? The 5th one that I didn't list is constituent involving activities, and I really think this one falls in line with and is linked to what the new enhanced class standards are trying to do. Because really what it talks about is working with the community to figure out who in that community we can hire, who's involved in delivering whatever services we're thinking about. One of the things that class says is that we really need to start thinking in terms of how we help build communities by having them involved in the workforce that is delivering all of these interventions. And when we're doing health messaging, when we got navigators, when we got lay health workers, rather than hiring outside of that community, we need to hire within that community wherever possible. And if it's training that's required, we need to think about being prepared to provide that training in order to be able to employ in that community. Because at the end of the day, we know that employment, jobs, economic development is a part of developing and promoting health. So one of the things that we have done in our work is, if everyone thinks doing the peripheral part of health communications or interventions is easy, but if you ever try to find things to do it, you realize it's not, because stock photos don't have a lot of diversity in them, and when they do, it costs. So one of the things that we did, we developed a photo library, True Colors, and we allow a lot of different groups to use it. If you follow Matt Kruder's work and the Health Communication Research Laboratory, the MEO systems that have come out of the laboratory allow community organizations to pool the photos that can be used to construct their own health communications. And you can actually still get copies of the True Colors photo library for free on CD, well, I guess those are still DVDs, that's what they are. It provides a wider selection of culturally appropriate photographs and available from stock photography files. These are some of the examples of some of the materials we had, and we did a lot of focus groups to figure out what we needed to have. And one of the things that people said is they like things local. They like everyday people. They didn't like the models. You know, it's hard to compete with the cute model with the nice outfit on, out jogging. You know, it's like, I don't look like that, and if I don't look like that, should I be out there? This helps people to figure out, just go and be you, and just the point is to be healthy and get some activity. We wanted to show people interacting in normal, everyday ways. And we wanted to get some health providers, and we had wonderful people in the St. Louis community health providers who agreed to participate, particularly ethnic minority providers, and we got a lot of those pictures. This is one of the, we were working on cancer. This is one of our colorectal cancer publications, and it gives you an idea. We found that the community members like specific colors, and they were less interested in certain things if the colors were wrong. And so we worked on colors, we worked on fonts. All of these things, as it turns out, matters. You will notice we use colon cancer instead of colorectal cancer because our people let us know. They know about colon cancer. For some reason, colorectal cancer does not translate. And so if we say colorectal cancer, people don't know what we're talking about. So we say colon cancer. But in the publications, we are constantly mixing the two to help them understand the link between the two. So when they're in other settings and people say colorectal, they make the link. And so all of these things matter. This was the outside. You can see our headings and titles. We selected those to convey this is for you and about you. We were focused on an African-American community, and so that became important. One of the things that people had said to us is that very often materials they put to the side because they think, this is not for me and about me. They see these as often as diseases for other people, and are surprised when the statistics show sometimes that there are substantial disparities. Now, this is one of the older versions of kiosks that were developed in the lab, and kiosks were used because you can incorporate all the computer technology and you are mobile in your ability to take health communication. These went into libraries, they went into laundromats, beauty shops, barber shops. Some of them dealt with breast cancer, they've dealt with colon cancer, HPV vaccination, and they ask the person a series of questions, and these can actually tailor to the individual as opposed to target. So the person gets all sorts of tips, they get information that we believe, based on our research, is likely to be more motivating. The tips that they receive are tailored specifically to them and their behavioral preferences. And so the point is, increasingly in the lab, we understand that it's important to put information where people are. It's important to give them the type of information that they want, and technology increases our ability to do that. You know, the computer can hold algorithms, take information from an individual, and spit out something in just a few minutes that it would take us working on our own all day to do. Organizations can create materials for their population based on aggregate data they have about preferences and characteristics of that population. Another piece that has become, but beyond just the use of the kiosks, we found that these applications can be used on iPads, notepads, and you can develop them to be used on phones as well. And so the point is that as our technology improves, we can take all the information we have on what makes health information easy for people to understand and use, and we can push it out in forms that people are actually using. We've also looked at other media sources for health that people go to for health information. And the ethnic minority media are trusted and valued by members of their communities, and they are underutilized in our efforts to speak to and work with disparate populations. African American newspapers have been tested and shown to be effective in broadening the reach of our cancer messages. Asian Americans have reported significantly stronger preferences for print materials, and we found that there are media sources there that we can make use of. And Hispanic use of media for health information has been found to differ from other ethnic minorities and varied by acculturation, but there have been successful efforts in this area using a combination of print and radio. I'm blocking on his name. Elmer Huerta has done a successful campaign driving people to use preventive care using ethnic minority media, not print, but a combination of radio and print. And so we know that this is important, but we rarely think about that when we're talking about our interventions and our communications. Evidential preferences, and we tested out the use of general statistical data, ethnic-specific statistics, statistics actually highlighting disparities, social math examples, positive and negative framing, whether we use survival or mortality data, and we found that there are some consequences of doing various things. Now, using general statistical data, people try to relate these to their experiences or behaviors, but usually if you're just providing people with data, as is sometimes done in stories, people walk away feeling unfulfilled. They indicate that they want more information on signs, symptoms, steps for change. Even if you give them signs and symptoms, what people want most are steps for change. They want it explicit. What am I supposed to do with this? And when we use terms like approximate and estimates all the time, and it doesn't bother us, it bothers members of the general public. And so people very often would indicate to us that obviously there's something wrong with our methods or our data, or we're trying to trick people, or we really don't know, which is why we use approximation and estimates. It's like, no, it's more complicated than that. But when you explain it, their response is, so what you're telling me is you really don't know. And so we learn not to do that. Ethnic-specific statistics are helpful in that they help people to see themselves as part of a high-risk group, but when you do that and it just comes out of nowhere, or the source is not a trusted source, mistrust surfaces, and people began to be suspicious of the sources, the statistics, and the motives for providing the data. So there are issues there. And consistent with past research that notes the appeal of health information that depicts members of the targeted community, this is good. The use of these is good because people feel like they're a part of it, but it's bad in the sense that people may have some questions about why they're receiving this information. We actually did a study of using racially comparative cancer information where it indicated that where we were trying to convey to people information on disparities and how certain populations were experiencing disparity. And what we found is that there's an unintended consequence of talking about disparities and telling people how much worse off their health is than other groups. People are less likely to intend to get preventive care when you do that than they are when you don't. They feel hopeless. And it's like, okay, what are you telling me? I already know. We got the worst this, the worst that. That's not positive. But we found we can frame in a way, we can do this in a way that is motivating. And what we found we had to do was say, okay, we acknowledge that things are bad, but what we want you to know is we've made progress, or you've made progress, the group has made progress. If you point out the progress that has been made and all the good things the community is doing, but say, but we still got a little more work to do, here's where we got to focus, and then give people action steps, that's motivating. And it's important for us to remember that we can beat a community down with the negative stats. We've got to be careful to give people hope and build them up. Use the strengths of the community. I think Dr. Melody Goodman was talking about strengths-based approach and making use of what communities have to offer. We've got to remember that in our messaging, and we too often forget. Social math is what we call creative epidemiology, and it's really simplifying the presentation of numbers. And so what we try to do is use examples from the community. So Rams Stadium or the Cardinals, where do the Cardinals play? Whatever we call where the Cardinals play. Bush, that's it. People look at me like, how can she forget that? But if we use those, we can convey to people, okay, so if everyone were in here, X number of people are likely to be diagnosed with this particular cancer, or, if you and your family are sitting together, at least one of you will be diagnosed with cancer, and sometimes, so we present statistics in that way. It's easier for people to hear it that way than the way we typically do, which is, 5-year probability of survival, or 90% of the people diagnosed in the early stages. People don't understand that, and they told us repeatedly, I don't get it. And when we asked them to interpret it, we realized they really were serious. They did not get it. We also figured out that positive framing worked better than negative framing. Talking about survival, 9 out of 10 people diagnosed early will survive is better than saying, 1 out of 10 people is going to die from this cancer. Because when people hear death, they fear. And they begin to see the disease as inevitably negative and no reason for action. And again, we take away that motivation for screening and early action. Let's see. So another issue to think about is whether you tailor or target. Now, when I talk about targeting, I'm really talking about focusing on the group. When I'm talking about tailoring, we get down to the specifics of the individual's needs. And computer technology permits a great deal more intersectionality. With that intersectionality, we can do a decent job targeting, but with computer technology, we can do a great job tailoring. And so where you have access from sources like the Health Communication Research Lab to use interactive systems that allow you to tailor, we advise that because you get better results in terms of people actually following through. And so just a few final recommendations. We need to really work toward more sophisticated articulation of sociocultural attitudes and their implications for behavioral interventions. My work has shown that we talk a lot about faith in the African American community, and we talk about mistrust, but there is a key issue that is not being used that my work is suggesting is very important, and that is attitudes about self-disclosure and privacy. Certain things people don't want to talk about and tell people. And if you can figure out how to address that and work around that, you get further in terms of understanding what people need and want and being able to really understand their barriers and address those. The ability to consider measure multiple cultural constructs and their distribution in the population at the same time to understand how to better target is important, but that's just us really learning to use the data that's available to us and doing it and using it as we develop our interventions, and understanding the use of media to develop effective campaigns with extensive reach, whether it's incorporation of technology, new technologies, or just using ethnic-specific media better. Thank you very much.
Good afternoon, everyone. So, I want to talk about LGBT health, but, and I made this kind of provocative title, LGBT health, what nobody knows, but also what we can do to change that. First of all, I want to provide a little bit of a context for talking about LGBT health. First of all, we have to keep in mind that homosexuality was included as a psychiatric diagnosis until 1973. This was in the DSM. If you were gay, you were mentally ill. If you want to hear the history of how that changed, go to who listens to This American Life. I kind of figured this demographic would. Anyway, go to thisamericanlife.org, download the podcast, 81 words. It's a fascinating story that has very little to do with actual medicine or evidence, and has to do a lot with society and how things have changed. Of course, laws prohibiting marriage between same-sex individuals often result in affect access of LGBT people to employer-sponsored health insurance. As Mr. Bao pointed out, one of the great effects for LGBT persons of the Affordable Care Act has been that a lot more people have access to health insurance. It's been a real boon for LGBT people, but that is an issue. There is, of course, a limited availability of providers who really have adequate training to treat transgendered patients in a culturally competent way. LGBT patients' previous negative experiences with the healthcare system are key, as we saw in the play that was done over lunch today. That sort of encounter is not uncommon. HIV/AIDS, the epidemic has resulted in the deaths of thousands of gay and bisexual men, and of course that cannot be discounted in terms of how people understand their health. And political pressures in the first decade of this century, and this is not political, this is historical. Many researchers who were doing work on LGBT health were told they could not use those terms in their populations. They had to use terms like special populations or things like that, which would make it difficult to search for. This was because of the policies of the administration in the first 8 years of this century. So that really stunted a lot of growth and study around LGBT health. So the thing is, what we do know, LGBT persons do suffer from health disparities, and we're going to talk about disparities at the moment, based on sexual orientation, gender identity, higher rates of smoking, substance use, depression, HIV/AIDS. There's also been a fair amount of evidence that women who identify as lesbians have higher rates of certain types of gynecological cancers. Men who identify as gay will often have more problems with eating disorders, those sorts of things. But what we don't know is really the actual scope of health disparities that LGBT persons have, not with the depth of knowledge and data that we know from other populations, just because that data has never really been collected, not in the sort of ways that it has for other populations. So, for example, someone can't go to data, like look at old NHANES data over decades because those questions had never been asked. So the thing is, part of the problem is how do you describe the population? People will say to me, so what percentage of the population is gay? And I go, I have no idea. We heard a statistic, earlier today that someone from the Department of Health said 1% of people in a Missouri Department of Health survey said they were gay. Well, that's nice. But what does that mean? Does that mean, first of all, does that mean what they do, what they feel, how they self-identify? Those are 3 different questions. Also, how safe do people feel identifying themselves as gay on a government-sponsored form in a state where you can be fired from your job, thrown out of your apartment, or denied service in a restaurant because you were gay? So it makes it really, really difficult to do this. Now, EBM, I am a pediatrician. I teach at a medical school, St. Louis University School of Medicine, and evidence-based medicine, of course, is what we strive for in everything we do. It has to be the basis for what we do. It's dependent upon data collection. There is not that much long-term verifiable data about LGBT populations, but the thing is that medicine without EBM, this is one of those dirty little secrets, is surprisingly frequent. We make a lot of decisions about patient care that has nothing to do with evidence-based. It's because, and one of the things, I have students, they're supposed to do these EBM projects, asking what's called a PICO question. P is patient or population, I is intervention, C is comparison, O is outcome. So the question might be, in a child under the age of 5 who has an ear infection, does prescribing amoxicillin immediately lead to improved outcome over delaying antibiotic use? And you can find all kinds of articles about that. That's a PICO question. The thing is that often when students ask these PICO questions about a patient we're seeing, things way outside of LGBT health, the answer is often, I don't know. That's never been studied. Isn't that interesting? The thing is, students don't like that, so they try to reverse engineer the question and come up with something better, and I say, don't do that. But the thing is, what happens in medicine is we'll say things like, well, that's the way we've always done it. Well, I had this patient once, or this study doesn't really fit, but it's the closest we've got. So, for example, the American Medical Association a couple of years ago actually came out in favor of same-sex marriage. And the reason they did is because they said that there have been a number of studies that show that marriage leads to longer life, improved health, all this stuff. But there are no studies of same-sex marriage that go back that long. Same-sex marriage has only been legal in Massachusetts. It's not even 10 years. May 17th will be the 10th anniversary, and that's it. So they extrapolated from studies of straight couples, people who'd been together in relationships but were not married. But sometimes it's the best we've got, and that's what we have to do. So 2011, the Institute of Medicine convened a panel, a 17-member panel, to come up with recommendations on LGBT health, and they came out with this report, The Health of Lesbian, Gay, Bisexual, and Transgender People, Building a Foundation for Better Understanding, which reviewed and prepared a report assessing the state of science on LGBT populations, looked at research gaps and opportunities, and outlined a research agenda to assist NIH in enhancing its research efforts in this area. And a lot of the recommendations were really about, we don't know, we need to get more data. And, you know, I'm sure that, Mr. Bao, were you involved with this? Okay. But I mean, yeah. But we all know people who were involved in it. And basically that's what it said. We have to ask these questions. The thing is, coming up with questions for this can take a couple of years to come up with a question that actually, and you know, you folks who do more of this kind of population-based research know that just asking the question, are you gay, is not going to get you the answer you want. So, we're still in the data gathering phase in a lot of ways. So again, the thing is that sexual orientation, gender nonconformity are multifaceted concepts. Defining them operationally can be challenging. And as I mentioned earlier, people may be reluctant to put this sort of information on a survey to say that, you know, yeah, I am. And because, you know, as was mentioned in the first panel discussion I went to earlier today, because the LGBT population is relatively small, generally samples are not done that overrepresent them to get the kind of statistical power that is necessary to make a lot of, for meaningful analysis. So I want to talk a little bit, you talked about some of these conceptual frameworks for looking at populations. One is called the minority stress model, and you guys are probably more familiar with this stuff than I am. Posits that persons in marginalized communities experience chronic stress as a result of their stigmatization. This is not specific to LGBT populations. This is specific, women experience this, people in ethnic, religious, racial minorities experience this, people of lower socioeconomic status. Intersectionality, as you mentioned, examines an individual's multiple identities and the ways in which they interact. Social ecology emphasizes that individuals are surrounded by spheres of influence, including families, communities, and society. And life course acknowledges that events at each stage of life influence subsequent stages and recognize that experiences are shaped by one's age cohort and historical context. So, I'm not going to go into a lot of detail on these things, but I think it's important to know what they are. So the thing is that if we don't appreciate all of these contexts, we're not going to get the kind of complete understanding of LGBT health that we need. So when we look at minority stress, while same-sex couples can now marry in 16, 17, I've lost track, 18 states. I mean, there's, you know, the courts will decide one thing and then they'll pull back on it, but it's quite a few states. And in D.C., in 29 states, it is still legal for persons perceived as LGBT to be fired from their job, evicted by their landlord, refused accommodation at a private business, and Missouri is one of those states. LGBT persons have no legal recourse. Believe this. I mean, believe me. I was the president of Promo for 6 years. I am now happy to be the immediate past president, but that's one of those things. We partner with the ACLU, and they have tried cases here and in other states. And if someone says, "I am not going to rent you a room at this motel because you're gay," there is absolutely nothing you can do about it. And people are shocked by that, but that's the truth. So the thing is that that does affect people. How willing are people to come out in that sort of environment, not just to their family and friends, but to their doctor? Because if their doctor does, you know, if they have to make a report to the employer because they have employee health insurance or to an insurance company, this information will get out there. They may lose their job. The life course framework, for me, it comes down to one thing: HIV/AIDS. I'm almost 60 years old. I'm a gay man. I was in New York in the early 80s, and this has shaped so much about my life, about who I am, about why I do the work I do. And everyone, I think we all have to think, what is it about my life and my experience that has shaped who I am? But this is sort of, you know, a sentinel event for me. Intersectionality, so we can, you know, have someone who comes into the office. They may be lesbian, gay, bisexual, transgender. We sort of lump all those together, but they're obviously very distinct. Still, a person is not just someone who is LGBT. They also have a race or an ethnicity. They also have a family. It may be a family of choice or a family that they are related to by blood. They also may be going to school. They have work that they do, and they have a religion. So For myself, I am a Caucasian, middle-aged, white, gay man who grew up in New York and was born in Pittsburgh, and I am a musical theater aficionado. That you probably didn't think was that surprising. Anyway, but the thing is that just, being LGBT doesn't tell you everything about me. And I think one of the things you were getting at is that sometimes we can kind of simplify things. And a lot of what cultural competence was about, I'll sort of comment on this, is that a lot of times we think, oh, let's give a lecture on how Vietnamese people think about health, or how Bosnians think about health, or how whatever. And that just does not make sense, because cultures may sort of believe kind of things, but you have to deal with one person at a time. So, for example, when I talk about musical theater, I'm all about Stephen Sondheim. Do not put me on a plane next to someone who loves Andrew Lloyd Webber. We will just kill each other by the end of the flight. So that's intersectionality. Then we look at social ecology. Again, that same LGBT person, those same bubbles. How does their race or ethnicity affect them? How does that culture affect being LGBT and their ability to express it? How accepted is that within their culture? How accepted is that within their family? Are they able to be out at school or at work? And what is the attitude of their religion toward that? As I mentioned earlier, I am a gay Catholic. That is sometimes complicated. It's been a little better the past year or so. But the thing for me, where I bring that together, and again, I'll be a little personal about this, when I was growing up in the 1960s on Long Island, that's how we say it, I was growing up in a white middle-class community. I was starting to realize I was different, and I was watching the civil rights struggle on the CBS Evening News with Walter Cronkite. And I was seeing people being beaten and attacked by dogs and knocked down by water cannons and all this stuff, and thinking how unfair it was as a human being, but also recognizing that there's something about me that if people knew that, they would treat me the same way. And so I was starting to realize that there was something different about me, and that I had an affinity with people who on the surface were unlike me. So that's part of why I've always worked in underserved communities. But that's also the point in church history, in Catholic church history, where John the 23rd, Vatican II, we were all being taught that if God gives you gifts, you give them to people who need those gifts. So for me, being gay and being Catholic aren't like this, they're like this. Together they call me to mission. And that's the kind of thing that I hope we can get to is, and I think you were talking about, it's not so much, we don't want to talk about disparities, we want to talk about strengths. How can all of these things bring us to wholeness when we're seeing people who are unlike us, and yet we recognize that there are things we have in common? I do want to talk a bit about the culture of medicine. Medicine has a very specific culture. As you were saying about cultural competency, knowledge, awareness, respect for other cultures, awareness of our own cultural assumptions. Oops, I skipped way ahead. So, physicians and other healthcare providers, of course, have our own culture, language, mores. One of the things about medicine is medical school is about 4 years learning a new language. You learn an entirely new language. It's really an important language to have so we can communicate efficiently, precisely, accurately. But when we use that language with civilians, it creates a barrier. The other thing about the culture of medicine is we're given a lot of respect. Whether we like it or not, whether we deserve it or not, we're given a lot of respect. And if physicians don't appreciate that, it can cause real problems. One of the things about doctors is that our culture, a lot of physicians, medicine's often been called a culture of no culture. Not that you're not cultured. It's a culture of, because physicians are so inculcated into the idea that everything we do is evidence-based, which of course we know is not true, but we think that everything is based on science and a deep-grounded Platonic reality. How can there be culture involved in that? Because this is what's real. People do things, other people do things because they believe in them, and that's cute, and we have to learn about that, but we are above all that. And so even breaking through that for doctors can be really difficult. So the challenge, of course, is to go from cultural competency to cultural curiosity, going to the point of just saying, oh, Vietnamese people believe this and Bosnians believe this, to cultural curiosity and saying to people, you know, what do you believe about your health? How do you perceive health? What are your feelings about what's going on with you? To finally cultural humility and realizing that I as a doctor believe these things because of something else that has gone on in my life or in my profession. Health literacy, of course, is key to all this. Healthy People 2010 defined it as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions, which, of course, is making sure that doctors and patients are speaking the same language. And it's interesting, even within the health literacy world, sometimes it puts all the burden on patients of, I mean, the way it's talked about, and that patients need to understand what the doctors are saying, and very little is put on the doctors about doctors need to remember we're talking to civilians. We're not dumbing it down, which is, of course, is a very culture-centric way of looking at it. We are speaking to other people. What I tell my students is I use the My Mom test. My mom was a brilliant woman. She never had formal schooling past high school graduation, but she read voraciously. She raised 5 kids. She kept a budget. And after we all left the house, she got a job at a bridal shop, and by the time she retired, she was running 3 stores. And so if she'd have questions about her health, and I try to answer them, if I started using, you know, medical words, she'd go, now, Kenny, I need to spend a lot of time learning those words. I'm your mother. Okay, Mom, there, I got you. So pretend you're talking to your mom. Pretend you're talking to someone you really like, who you really know, who's really smart, and don't try to impress them with these words. And then the final thing, I mentioned this in my remarks earlier, doctors hate to talk about sex. And when it comes to LGBT stuff, even though most of the stuff that people who are LGBT come in with have nothing to do with sex, doctors think sex. When I was first in practice, I was in East St. Louis for the first 10 years of my practice. And in about 1990, I got this videotape from the Illinois State Medical Society, a videotape, VHS, on how to take a sexual history. This was 1990. And they sent it out because people were so bad at doing it. So it's just in general, people don't like to talk about it. So if someone comes in who has a sexual orientation or a gender identity as part of what's going on and I need to deal with as a doctor, a lot of doctors go, okay. So what do we do, either as providers or as the general public? One of the things the Joint Commission has also in 2012 put out a 99-page guide for care for LGBT patients and families that addresses a lot of these issues. This is significant because we all know the Joint Commission, who they are. It strikes fear into the hearts of everybody. And so people around the country will look at this and go, they're going to ask us about this someday. We got to think about it. So that's important. As you know, the Missouri Foundation for Health, they put this out last year. Some of the key findings: sexual gender minorities 1.5 times more likely to be uninsured. LGBT Missourians from racial and ethnic minorities have poor health outcomes. Surprise. LGBT families are more likely to be poor. This again goes against the stereotype that, you know, of gay men going off to Cancun every weekend. I've never been to Cancun. 2/3 of healthcare organizations do not require their physicians to attend LGBT health competency literature, training. Promo has gotten as was mentioned earlier, got a grant from the Missouri Foundation for Health. Andrew Shaughnessy is our staffer. We do this in partnership with SAGE Metro St. Louis. Cheryl Wayland is their executive director. Oh, it's time for me to stop. Anyway, but we're working to eliminate health care disparities. And so what all of us can do, the opportunity is, this is a rich area for research, education, direct care, advocacy. And it's important when people talk to their doctors to remember that doctors have a culture too, you know, and so as I think that when, you know, one of the things I tell people who are talking to me who are LGBT saying they're afraid to go to their doctors, the vast majority of doctors they just don't think about this. It's not that they really don't like LGBT people, they just don't think about it. So if someone asks a guy, do you have a wife? Say, well, no, but I've got a husband. And do with a smile, people go, oh my God, okay, I didn't even think about that. You know, I tell people to give your doctor the benefit of the doubt, and if they're a jerk, let me know on Facebook. Anyway, thank you all very much.
So Thank you so much. We have about 12 minutes left. I think that now we are open to any questions to our panelists. Yes.
My question's for Jeremy. You mentioned that the 8 million were covered, who got coverage under the marketplace through the ACA, isn't really helping the people we're talking about aren't fully. The disenfranchised people that we're here to talk about today aren't necessarily part of that. Did I misinterpret that?
Not really. Okay, here's where I'm coming from with that. We had a lot of stakeholders involved in this, okay? And there were at least one or two meetings that we were invited to where we would have representatives from the actual insurance companies that were selling insurance in the private exchanges, and they would a lot of the stakeholders would say, well, we really got to get these young people to sign up. We have to get these young, invincible people to sign up for for insurance through the exchanges to balance out the risk pool. Because if it's all older, sicker people, then the insurance companies it's going to go into this big death spiral. And we have a no wrong door policy in the in-person assister program, and anybody who comes to us for help is welcome, and we're happy to help them. But the thing is, that is not our target population. Our target population, it's written into our grant proposals, are the people who fall through the cracks. So when we're talking about 8 million signups, well, a lot of those people did that on their own, because they were able to. Maybe they had the wherewithal to do it. Maybe they were able to figure out the website. Maybe they were able to understand the nuance behind all the questions on the application for financial assistance. But that wasn't representative of the people that we were helping. We were more of the canary in the coal mine when it came to the people that would normally have fallen through the cracks. Okay. Because this was mostly the bulk of this, and this is generalizing a great deal, but the bulk of this system was it more or less caters to people who are very comfortable with a website and organized and prone to documenting things, keeping their paperwork, being tenacious. People who are less likely to do that, people who kind of just stumble into things, or maybe they don't think about this until 4 p.m. on March 31st. Those are the people that were more likely to come to us. We saw a lot of people who tried, and by the way, we saw a lot of people who tried on their own, who tried to apply on their own and couldn't figure it out, and then came to us. So that's what I'm talking about when I say, well, you look at the 8 million, we're a part of that story. You're welcome. Yes. I assume it's for me. I'm sorry.
Oh, sure.
She's making eye contact.
That's good.
I do have a question for you, and it has to do with, I need to understand something. So the people who are slipping through the cracks, so the immigrants now, who have been here for more than 5 years, or less than 5 years, excuse me, they're not eligible for Medicaid, but they can get subsidies in the marketplace. But I'm thinking about those who are then excluded, so the population that's living through the cracks.
Right.
And there's this weird thing that happens, right, where people are resentful. So one population is getting this special thing,
That's right.
but this other isn't. Like, how do you, or how do we get over that? They're getting something that I'm not, as opposed to let's raise all boats.
That's a really good question. There's a Russian proverb that touches on this, where the magistrate's going through a village, and there's a villager who's very depressed and despondent, and he says, "Why are you depressed and despondent?" He's like, "Well, my neighbor has a cow, and he's much wealthier than me because he has his cow and he can sell the milk." And the magistrate says, "Well, what can I do to help you?" He says, "Go kill the cow." and that sheds light on the fact that when there is one population that has something and the other one doesn't, it causes a lot of stress.
I want to promote this, but I don't want to create resentment.
No, the most thing I think the best thing we can do is promote understanding of it. and put it into the context that this was designed for people who truly had no options, people who truly had no access to affordable health coverage. You may have heard, I don't want to get too much into the weeds as far as eligibility. We could talk after if you like. But we had events where there were people who, on one end of the room, you had people hugging the navigator, and they were very happy, and they had, the plan was covered a whole lot and was cost less than a cell phone bill. And then you had somebody else, Medicaid gap, and they didn't understand why, the guy across the room was all smiles and hugging the navigator, and here I am, and my situation isn't changed at all. And a lot of people in this, who are falling through these cracks, they didn't understand the separation of powers. They didn't understand that there's a state government and a federal government. It's like, why has Obama abandoned me? My income is less than $11,490 for the year, and I have no help. But somebody making $11,500, they have basically free health insurance. So yeah, there are some very stark differences, and it was hard to explain. And what I would kind of jump back to is, we are mostly educators. In a lot of the stories that focused on the in-person assisted program, they talked about, sign-ups and how many people are going to sign up, and we had lots of sign-ups today. We were mostly educators. The best thing we did for people was we helped people understand where they stood with this law. Even when the site was down, even when there were connection errors, we could figure out where people stood with this law based on our knowledge of the law and pencil and paper, and fortunately that didn't require connecting to a server.
So should we have more questions around here? Okay, yes.
I would like to ask Dr. Sanders-Thompson a question about, I found your discussion of all the different factors involved in appropriate communication to be fascinating. But I'm kind of left with, short of engaging your center to design every community-based communication effort, what's your advice when working within a community, like here in Columbia, for example, we're working to try to target some of the health disparities and try to get people hooked up with the care that they need. What are the best sources of information about how to do that practically?
In terms of finding the appropriate information for specific target populations?
Partnering, or even specific conditions that you want to be trying to address.
I think one of the things is we do not advocate people develop a lot of their own communications because it is a complex process. And there are people who spend a great deal of time developing materials. And so what we do recommend to people and advocate is that people access the materials that have already been developed. And CDC has some of those. Interestingly enough, ACS does a really good job with some of their materials. They underwent a process to develop their accessible and diverse education materials. Other disease foundations and non-governmental groups have done similar things. You can get information that way. Searching the web often allows you to find what people have developed and what they are providing free of charge, and we recommend that people do that. And then when you get materials, we advocate that people go through those materials and sort of rate them to determine, what do the peripherals look like? Read through them and determine, do these speak about more than just the sort of mainstream population? We also recommend that when people are thinking about where they want to put their messaging, think about the local media. Think about communicating with them and letting them help you figure out the local spot you want to do and have a helping you find the local spokesperson you want to use. So localizing. Making the effort to localize and use the resources within the community. The media people within your community, many of them know everything that I said to you today. When we're at conferences, they're saying pretty much the same things. So using your local media, using the resources that are already developed and figuring out what will work in your community, which means bringing some of your community members to the table and saying, hey, take a look at this. What do you think? Can we use it here? And very often they'll say, this is fine. They might have a few tweaks they want, but sometimes they'll say, but if you can't do that, this will work. But we don't like this one or this one. And there are some bad things out there that they'll easily identify for you.
So I think that we have one more question to receive. I think Ivana, you have a question, right?
I know initially, I think one of the studies that I read you did was looking at the preferences for African American parents when it came to HPV vaccination. And I was really interested in that, so I'm sorry, I'm sure there's not enough time, but if you could say like the main finding or something that came out of in that work.
The main thing that came out in that work was that a lot of the discussion around religious issues and mistrust informing the HPV decision-making has not held out in our work. What has concerned people most is the information available on safety, and side effect profiles, and the lack of understanding of the 3 shots and the timing of the shots. That's really what trips a lot of people up. But we've done a lot of pushing of HPV strictly on a marketing basis, and we haven't done a lot of educating. And I think that we're at a point with vaccinations and attitudes about vaccine where you really have to do some education. And people don't feel like that's readily available. And what's out there has not been translated into something that's more lay, that people can understand. And this is the point that I've made or tried to make in some of my work, that we're at a point where we don't have to see a disparity in the HPV vaccination rates, and we're really not seeing much of one at this point. As long as we continue to focus on meeting the needs of the communities, educating, using the language, getting out into communities and talking to people and giving them the information that they want. If we can do that, then this will be one time when we're not doing that well with anyone. That's not good. But at least we're not doing less well with some groups than others. And so as long as we can keep focus, I think we'll be okay on this one, but really, we've just got to do a better job all the way around.
Yeah, and if I could comment on that as a clinician who sees a lot of kids, I think a lot of this gets to health literacy too, in terms of what information people really need. And some scripting that I've found that has worked for me, and I'm sorry, it's completely anecdotal, but when kids come in at 11 years of age, what I'll say is, now remember, at the end of the visit. Now, remember when your child was 4 years old and going into kindergarten, we gave your child some shots to take care of, to prevent illnesses that your child would get in early childhood. Now that your child is 11, there are 3 shots that your child needs that will help them as they're entering adolescence. The first is the tetanus shot, and you're going to get that, and we'd like to give that one today, and then she'll need that every 10 years after that. The second is called Menactra, and that prevents a type of bacterial infection that causes meningitis, which is a really bad infection of the brain and spinal cord. And for reasons we don't quite understand, that seems to be most common in kids who are teenagers and young adults. So we give that one today, and we give that one when she's 16 years old. The third is called Gardasil, and that protects against a virus called HPV. Now, what that virus does is it causes cervical cancer. And this vaccine can prevent about 2/3 of those cancers, which means it'll save about 2,500 lives a year. The schedule for that is we give one of those today, one in 2 months, and one 4 months after that. Now, do you have questions about that? What questions do you have? And when I put it that way, people go, oh, that's fine. Go ahead. Just that, and putting it in a context of, we did this at 4 years of age, we're doing this now, and this is the schedule. And sometimes people do have questions, I answer them, and that's about it.
And what we're seeing, even when we go in the HINTS database, the Health Information National Trend Survey, and some of the other databases, really what people are saying is that if they get that script from their physician, no brainer. But a lot of them are not getting that. Right. People are not talking about it, partially because they don't want to talk about sex.
Right. And actually, I don't bring it up. And now the thing is, the question I will sometimes get is, well, how does someone get HPV? And I'll say, well, it's a sexually transmitted virus. And they go, oh, and I go, that's why we want to give it now, long before she's ever going to have sex. Like, I really say it that way, like long before. Oh, okay, that makes sense. because the thing is, what happens is, I've heard people go, okay, well, we want to give them an Actra, that's the meningitis shot, and the tetanus shot, and then there's the third one, it's called Gardasil, that protects against the sexually transmitted disease. Do you want that one too? People go, no! No one wants to think about their 11-year-old having sex. But when you script it that way, and be a little bit humorous about it, people are generally like, oh yeah, it's fine, yeah, that's great.
Okay, so thank you so much, and then we will have about 10 minutes, and then we'll meet 3:45. We will meet at community action session soon. Okay, thank you so much again.
Yeah.